Hello and welcome to today's presentation. We are looking at ophthalmology nursing. This is simply a specialized nursing field that is normally focuses on care for patients with eye conditions and diseases. So as an RN registered nurse, you need to have excellent skills in patient assessment and history taking so that you are able to conduct a detailed patient interview and gather information about eye health, medical history, and current symptoms. You also need to be able to have quick diagnostic testing so that you're able to perform and assist with eye examination, and diagnostic tests will be including the visual acuity tests, the tonometry, the one that is used to measure intraocular pressure, and some of the imaging tests. All right. Patient education, that is another skill that an RN you need to have, so you are able to educate the patients about eye health, prevention of diseases, also or teach on post-operative care and the use of some medications, especially the eye drops. You also need to be able to assist in procedures. So you assist the ophthalmologists during surgical procedures like cataract surgery and minor in-office procedures like the removal of foreign bodies and laser treatment. You also need to have excellent skill for medication administration, as you know that this is one of the core roles of an RN. So you'll be able to administer the eye medications, including the drops, the ointments, the injections, usually prescribed by the ophthalmologist. You also need to be able to provide pre and post care to patients just before and after eye surgeries, including patient preparation, monitoring recovery, and managing post operative complication. You should also be ready to handle ocular emergencies like trauma and acute glaucoma attacks, like for the closed ankle glaucoma, retinal detachments, and other severe conditions. Lastly, you need to be able to work closely with other healthcare providers, including the optometrists, the primary caregivers, and specialists in related fields, so that you can be able to provide a comprehensive care to your patient. So we have some of the top 10 conditions in ophthalmology nursing, starting with the cataracts. We have glaucoma, macular degeneration, retinal detachment, and diabetic retinopathy. We also have the pink eye, conjunctivitis, corneal ulcer, uveitis, trachoma, and some of the common refractory errors. So, looking at the eye of a human being, that is our focus. This is a very sensitive organ. It's highly specialized and is responsible for vision. So, if you have a disorder related to this organ, it's going to lead to impaired vision. So when somebody has impaired vision, it's going to affect some individuals' dependency in self-care, work, and also lifestyle choices, sense of self-esteem and safety, ability to interact with the society and the environment, and the overall quality of health is going to be severely compromised. Leading causes of visual impairment are cataracts, which is number one, followed by glaucoma and also macular degeneration. Statistics show that two-thirds of the visually impaired population are older than 65 years, and that shows that age is a leading risk factor for these problems. Younger patients are also at risk for eye disorders, particularly if you have traumatic injuries like the traumatic cataracts. Studies also show that patients receiving health care in a facility will always have an eye disease as a comorbid. So RNs are supposed to assess the visual acuity in patients at risk and also help them just to adapt to the impaired vision. So when you have the eyeball as one of our major parts, describing it, this eyeball sits in a protective bone structure that we refer to it as the orbit. This orbit is normally lined by muscles and connective together with adipose tissues. And this orbit is about 4 centimeters high, wide, and even deep. and it is shaped roughly into four-sided 4 centimeters pyramid that is surrounded by three sides of sinuses, and these sinuses are the MEF. These are the maxillary, which is inferiorly, and the ethmoid medially, and the frontal, which will be superiorly. So the optic nerve and the ophthalmic artery, they normally enter the orbit at its apex through the optic foramen. So we have at least different parts of the eye where you can be able to see. You can be able to see the sclera, followed by the choroid, and then the retina. Then we have the ciliary body that is going to be producing the aqueous humor. We have the suspensory ligament that hold the iris. Then you have the pupil around here, the anterior chamber, the cornea. We have, this is the shaped, the dome shaped part here, right? The cornea, right? Okay, so the eyeball is normally moved in through the fields of gaze by the extraocular muscles. We have 6 muscles, where 4 rectus muscle and 2 oblique muscles, right? And these ones are innervated by nerve 3, nerve 4, and nerve 6. So normally the movements of these two eyes are coordinated so that the brain is only able to perceive one image. So we have the superior rectus, which is involved in upward movement, and the inferior rectus, this one does the opposite, is involved in the down movement. We have the medial rectus, which is involved in facilitates inward movement, and the lateral rectus, which does the opposite by facilitating the outward movement. Then you have the inferior oblique. This one is involved in the upward and outward movement, while the superior oblique, downward and outward movement. So those are the 6 muscles that are involved in the moving the eye in the different gazes. We have the eyelids, and these eyelids, they cover straight-head and smooth muscle just to protect the anterior portion of the eye. The eyelids contain multiple glands, including the sebaceous, the sweat, the accessory lacrimal glands, and they are lined with conjunctival material. So the upper lid normally covers the most portion of the iris and is innervated by nerve 3, that is the oculomotor nerve. The lid margins contains the meibomian glands, the inferior, superior puncture, and the eyelashes. Somebody could have a disorder where we normally refer to it as the homobedian internal stye, and this is just the infection of the tarsal gland of the eye. We'll also suffer from blepharitis, which is characterized by eyelids swollen and reddened. From there, we go to the triangular spaces formed by the junction of the eyelids. So that we have the medial one, which is referred to as the medial canthus, and the outer one, all right, the lateral one, which is referred to as the lateral canthus. So the canthus of the eye, we have the medial and the lateral. So with every blink of the eye, the lids normally wash the cornea and the conjunctiva with tears. Tears are vitally important to the eye health because they are formed by the lacrimal gland and the accessory lacrimal glands. So a healthy tear will be composed of 3 layers, where we have the lipoid layer, we have the aqueous, and we have the mucoid. If there is a defect in the composition of these layers, the integrity of the cornea will be compromised. Remember, tears are normally secreted in response to reflex or an emotional stimuli. Next, we have the conjunctiva, which is a mucous membrane that provides a barrier to the external environment and nourishes the eye. We have globulate cells of the conjunctiva, and these ones, they do secrete lubricating mucus. So we have two major parts here. We have the bulbar conjunctiva. The bulbar conjunctiva covers the sclera, right? The sclera, while the palpebral conjunctiva here it lines the inner surface of the upper and the lower eyelids. So this palpebral conjunctiva and the bulbar conjunctiva, they normally meet, okay, they normally meet in a place where we refer to as the fornix, right? So we have the conjunctival fornix as the place where the two portions of the conjunctiva meet. From there we go to the sclera, right? The sclera, this is also commonly referred to as the white of the eye. It is dense, fibrous structure that comprises the posterior 5/6 of the eye, right? 5/6 of the eye. The sclera helps in maintaining the shape of the eyeball and protects the intraocular contents from trauma. The sclera may have slightly bluish tint in young children, or could be dull white in adults and slightly yellow in the elderly patients. Externally, it's overlaid with the conjunctiva, which is a thin, transparent mucous membrane that contains fine blood vessels. You remember that the conjunctiva and the cornea, they normally meet at a region referred to as the limbus on the outermost edge of the iris. So we normally commonly refer to it as the CCL, the conjunctiva and the cornea meeting at the limbus, right? Okay. The cornea is a transparent and it is avascular, so that means has no blood vessel. So this makes treatment of the cornea to be so challenging. The cornea is shape is dome-like shape, and you can be able to see how it's carved on this surface, right? The cornea, and it forms most anterior portion of the eyeball and is the main refracting surface of the eye. I mean, it contributes around 2/3 of the refractory power of the eye. So the rest, the third, is shared by the other structures, but cornea is the main part here. The cornea is composed of 5 layers. We have the epithelium, we have the Bowman's membrane, we have the stroma, we have the segment membrane, and the endothelium. The epithelial cells are capable of rapidly replicating, and they are completely replaced every 7 days, right? Behind that cornea, there lies anterior chamber, which is normally filled by a continuously replenished supply of clear aqueous humor, which nourishes the cornea. So the aqueous humor is normally produced by the ciliary body, as we had suggested. So the anterior chamber is here, the space between the cornea and the iris, right? The iris, and so we have it here. Okay, all right. So its production is what is related to intraocular pressure, and the normal pressure is normally within 10 to 21 millimeters of mercury. Uvea consists of the iris, the ciliary body, and the choroid. So the iris, which is the colored part of the eye, this one is highly vascularized, is a pigmented collection of fibers surrounding the pupil. The iris is responsible for controlling the amount of light that will enter the eye, and the pupil is simply the space that dilates or constricts in response to light. So normal pupils are normally round and constrict symmetrically when when bright light shines on them. But we have about 20% of populations who have pupils that are slightly unequal in size, but they respond equally to light. So, and it's a normal finding. Dilatation and constriction are normally controlled by the sphincter and the dilator papilla muscles. So the dilator papilla muscles are controlled by the sympathetic nervous stimulation, while the sphincters are controlled by the parasympathetic stimulation. Directly behind the pupil and the iris lies the lens, which is a colorless and almost completely transparent biconvex structure held in position by the zonular fibers, the suspensory ligaments. It is avascular and has no nerve or pain fibers, right? And the lens enables focusing for near vision and also refocusing for distance vision. So the ability to focus and refocus is what we commonly refer to as accommodation. So the lens is normally suspended behind the iris by the zonules and is connected to the ciliary muscle. The ciliary muscles controls accommodation through the zonular fibers and the ciliary muscle. The aqueous humor, which is produced by the ciliary body, is anterior to the lens and posterior to the lens in the vitreous humor. All cells formed throughout life are retained by the lens, which makes the cell structure of the lens susceptible to degenerative effects of aging. The lens continue to grow throughout the life, laying down fibers in concentric rings. This gradual thickening becomes evident in the fifth decade and eventually result in increasingly dense core or nucleus, which can limit accommodative powers. And this could result in pathologies like the cataracts. So the posterior chamber is a small space between the vitreous and the iris, and aqueous humor is manufactured in the posterior chamber by the ciliary body. Then this aqueous fluid will flow from the posterior chamber to the anterior chamber, from where it will drain through the trabecular meshwork into the canal of sclera. The choroid lies between the retina and the sclera. It is a vascular, it is a vascular structure, and so it has blood vessels supplying blood to the portion of the sensory retina closest to it. Posterior chamber, this is the chamber that lies in between the iris and the lens. The lens is behind the iris and normally clear. Light will pass through the pupil to the lens. Then the lens is held in position by the zonules. The ocular fundus is the largest chamber of the eye, and it contains the vitreous humor. Vitreous humor is a clear gelatinous substance composed of mostly water and encapsulated hyaloid membrane. So the vitreous humor occupies 2/3 of the eye volume and helps maintain the shape. As the body ages, the gel-like characteristics are gradually lost and various cells and fiber cast shadows that the patient now start seeing floaters. The vitreous humor is in continuous contact with the retina and is attached to the retina by scattered collagenous filaments. Vitreous humor normally shrinks and shifts with age. So the innermost surface of this fundus is the retina, and retina is composed of 10 microscopic layers and has the consistency of the wet tissue paper. Retina is a neural tissue and is an extension of the optic nerve. So viewed through the pupil, the landmarks of the retina will include the optic disc, retinal vessels. We have the central retinal vein, central retinal artery, and now we have the macula, right? The macula. And at the center, we have now the fovea centralis. So the point of entrance of the optic nerve into the retina is the optic disc, and the optic disc is oval or circular and is pink and has sharp margins. In the disc, there is a physiological depression or a cup that is present centrally, which the blood vessels will be emanating from. So the retinal tissue arises from the optic disc and line the inner surface of the vitreous or the vitreous humor, right? So optic disc, we had already located it. Retina is the innermost layer. All right. Retinal vessels also enter the eye through the optic nerve, branching out through the retina and forming superior and inferior arcades. The area of the retina that is responsible for central vision is what we're referring as macula, right? And we have some pathologies which we refer to as macular degeneration, where we now have a problem with the central vision, and this is how images start appearing. So the rest of the retina is responsible for peripheral vision, while the center is responsible for the central vision. So in the center of the macula, we have the center of the macula. This one is the most sensitive areas, and this is named as the fovea, which is a vascular and surrounded by the superior and inferior vascular arcades. We have two important layers of the retina. We have the retinal pigment epithelium and the sensory retina. So when talking about the sensory retina, this sensory retina contains the photoreceptor cells, which are the rods and cones. So the rods and cones are long, narrow cells shaped like rods and cones. When you talk about rods, these are simply responsible for night vision or vision in low light, while cones provide best vision for the bright light, color vision, and fine details. So cones are distributed throughout the retina, with their greatest concentration being the fovea, the central part, while rods will be absent in the fovea. So good visual acuity depends on the health and functioning eyeball and an intact pathway. This pathway is made up of the retina, the optic nerve, optic chiasma, optic cracks, lateral geniculate bodies, optic radiations, and the visual cortex area of the brain. The pathway is an extension of the CNS. So the optic nerve is also referred to as this second cranial nerve. Its purpose is just to transmit impulses from the retina to the occipital lobe of the brain for interpretation. The optic nerve head or the optic disc is the physiological blind spot of each eye. The optic nerves leave the eye, then meet the optic nerve from the other eye at the optic chiasma. Then the chiasma is the anatomical point at which nasal fibers from the nasal retina of each eye cross the opposite side of the brain. The nerve fibers from the temporal retina of each eye remains uncrossed, right? We have them. So that we have fibers now from the right half of each eye, which will be the left visual field, therefore carry impulses to the right occipital lobe. And then fibers from the left half of each eye or the right visual field will carry impulses to the left occipital lobe. So beyond the chiasma, these fibers are known as the optic tract. The optic tract will continue to the lateral geniculate body. The lateral geniculate body leads to the optic radiations, then to the cortex of the occipital lobe of the brain. Okay guys, so that marks the end of the anatomy of the eye. We can see how to take history of a patient with the eye problem. When taking ocular history, you want to ask the patient, does the patient perceive to have a problem? Is the visual acuity diminished, so you have to perform it? Does the patient experience blurred, dual or distorted vision? Is there pain? Is it sharp or dull? Is it worse when you blink? Is the discomfort an itching sensation or a more of a foreign body sensation? Are both eyes affected, or is there any history of discharge? If so, you question the color, the consistency to find out. In ocular examination, after the patient's main problem, that's the chief complaint or the concern has been identified, the history has been obtained, visual acuity has to be assessed. This is an essential part of the eye examination, and it's a measure against which all therapeutic outcomes will be best. So we have the visual acuity, where we are going to use the standard Snellen chart, which is composed of a series of progressively smaller rows of letters and is used to test distance vision. The fraction is normally 20/20, which is considered the standard of normal vision. Most people can see objects on the line designated as 20/20 from a distance of 20 feet. If a person with a vision is 2200, this one can see an object from 20 feet away from that person whose vision is 20/20 can see from the 200 feet away. The patient is normally positioned at a prescribed distance, usually 20 feet from the chart, and is asked to read the smallest line that he or she can see. The patient should wear distance correction glasses if required, and each eye should be tested separately. So you have to wash your hands and don the PPEs if appropriate. You introduce yourself to the patient, including your name and role, then confirm the patient's name and date of birth. You briefly explain what the examination will involve using patient-friendly language. Then you gain consent to proceed with the examination, position your patient in sitting on a chair, then ask the patient if they have any pain before proceeding with the procedure. So they have to stand the patient at 6 meters from the Snellen chart, which is equivalent to 20. Okay, ask the patient to cover one eye and then read the lowest line as they are able to. Then you record the lowest line the patient was able to read, e.g. 66 metric, or which is equivalent to 20/20 in period. You can have the patient read through a pinhole to see if this will improve the vision. And if the vision is improved through a pinhole, it suggests that this guy could be having a refractory component to the patient's poor vision. So you have to repeat the above steps with also the other eye you record. Visual acuity is normally recorded as the chart distance, that is the numerator, over the number of the lowest line read, the denominator, right? Numerator over denominator, right? So the numerator is the distance. So if the patient reads the 6 line suggests as line but gets two letters incorrect, you will record that this is 6 then in bracket -2. If the patient gets more than two letters wrong, then the previous line should be recorded as their acuity. This, when recording the vision, it should state whether the vision was unaided, that is UA, with glasses or with a pinhole. If the patient is unable to read the top line of the Snellen chart at 6 meters, even with a pinhole, you move through the following steps. You have to reduce the distance to 3 meters from the Snellen chart. This equity will be recorded as 3, okay, over the denominator. So you have to reduce the distance to 1 meter from the Snellen chart. That will be now 1 meter over the line that has been read, which is the denominator. You assess if they can count the number of fingers you're holding, then this will be recorded as counting fingers, or that CF. You assess if you can see gross hand movements, and then this one will be recorded as HM. And you assess if the patient has can be able to detect light from a pen shown through the eye, and this will be recorded as NPL. So the external eye examination is normally performed after the visual acuity has been recorded. So the position of the eyelids is normally noted. Commonly, upper 2 mm of the iris is normally covered by the upper lid. The patient is examined for ptosis. This is the dropping of the eyelid. For lid retraction, that is too much of the eye is exposed. That should be assessed. Sometimes the upper or lower lid turns out, affecting the closure. So the lid margins and lashes should have no edema, or lesions. The RN looks for scaling or the crusting, so the sclera is inspected, and then a normal sclera is supposed to be opaque and white. Remember, referred to as the white of the eye. Lesions on the conjunctiva, discharge or tearing or blinking are normally noted. The room should be darkened so that the pupils can be examined. The pupillary response should be checked with a pen light to be certain that the pupils are equal, reactive, and regular. A normal pupil is black, and an irregular pupil may result from trauma, previous surgery, or a disease process. The patient's eyes are observed in primary or direct gaze, and any head tilt is noted. A tilt may indicate maybe we have cranial nerve palsy. The patient is asked to stare at a target. Each eye is covered and uncovered quickly while the examiner looks for any shift in gaze. The examiner observes for nystagmus. Nystagmus is oscillating movement of the eye. The extraocular movements of the eye are simply tested by having the patient follow examiner's finger or hand light through 6 cardinal direction of the gaze. We have the up, right, for the superior, down for the inferior, right for the lateral, left for the medial, and both diagonals. This is usually important when screening patients for ocular trauma or neurological disorders. Ophthalmic evaluation, that is direct ophthalmoscopy. Okay, you are going to use a handheld instrument with various plus and minus lenses. So the lenses can be rotated into place, enabling the examiner to bring the cornea, lens, retina into focus sequentially. The examiner will hold the ophthalmoscope in the right hand and uses the right eye to examine the patient's right ear. The examiner will switch to the left hand and left eye when examining the patient's left eye. During this examination, the room should be darkened and the patient's eyes should be on the same level as the examiner. The patient and the examiner should be able to breathe comfortably. All right, and the patient is normally given a target to gaze on and encouraged just to keep the eyes open and steady. So when the fundus is examined, the vasculature comes into the focus first. Look at the veins. The veins are larger in diameter than the arteries. The examiner should focus on a large vessels, then follow it towards the middle of the body, which leads to the optic nerve. The central depression in the disc is known as the cup. The normal cup should be about 1/3 of the disc. The size of the physiological cup should be estimated, and ask yourself, are the disc margins sharp or are they blurred? Do the veins have a silvery or a coppery appearance? Remember, there should be no hemorrhage seen in the normal fundi. Any yellow, white, gray, or black interruptions in the background of the retinal could suggest that this is probably pathological exudate or edema or the scar. There should be no wrinkling in the retina and any chalky whiteness or erythema of the disc that will be noted as an abnormal indistinct disc margins. The periphery of the retina can be examined by having the patient shift his or her gaze. And the last area of the fundus to be examined should be the macula because it is the most light sensitive part. The retina of a young person has often a glistering effect, which is sometimes referred to as the cephalophen reflex. The healthy fundus should be free of any lesions, as we have suggested, indicated in the previous slide, and you look for any intraretinal hemorrhages which may appear as red smudges, and if the patient has hypertension or you may have to look for any white, somewhat flame shaped. Lipid may be present in the retina of patients with hypercholesteremia or suffering from diabetes. This lipid has a yellow appearance. So soft exudates that have a fuzzy white appearance should be also be noted. The examiner looks for microaneurysms, which look like little red dots or navy. We have the drusen. These are small hyaline globular growths. These are commonly found in macular degeneration. Appear to be yellowish areas. With distinct margins. Small druven can also, we could have a more distinct edge. The examiner should sketch the fundus and document any abnormalities after the examination. What about the indirect ophthalmoscopy? Indirect ophthalmoscopy is an instrument commonly used by the ophthalmologist, and it produces bright light and intense light. The light source is affixed with a pair of biocular lenses which are mounted on the examiner's head. So the ophthalmoscopy is used with the handheld 20 diopter lens. This instrument enables the examiner to see larger areas of the retina, although in unmagnified state. We also have the slit lamp examination, and the slit lamp examination is a binocular microscope is mounted on a table. This instrument enables the examiner to look at the eye with a magnification of about 10 to 20 times the real image. This illumination can be varied from a broad to a narrow beam of light of different parts of the eye. For example, by varying the width and intensity of the eye, the anterior chamber can be examined for signs of inflammation. Cataracts may be evaluated by changing the angle of light, and when a handheld contact lens, such as a 3-mirror lens, is used with the slit lamp, the angle of the anterior chamber may be examined, as may the ocular fundus. We also have the color vision testing, and this is the ability to differentiate colors. It has a dramatic effect on activities of daily living. For example, inability to differentiate between red and green can compromise traffic safety. For drivers, you have to understand this. Some careers like commercial art, color photography, airline pilot, electrician may also be close to the people with significant color deficiencies. The photoreceptor cells are responsible for color vision. Of course, we had mentioned are the cones, and the greatest area of color sensitivity is the macula, okay, the area of the dense cone concentration. So a screening test such as the polychromatic plates discussed in the next slide can be used to establish a patient's color vision within the normal range. Color vision deficits can be inherited. For example, the red-green color deficiencies are inherited in an X-linked manner, and this affects approximately 8% of men and about 0.4% of women. Acquired color vision losses may be caused by medications such as digitalis, that patients will say they're seeing halos around lights. Also pathologies such as the cataracts. So a simple test such as asking a patient if the red top of a bottle of eye drops appears redder to the eye than the other can be effective. Changes in appreciation of the gradations of the color red, and also indicate macular or optic nerve problems. Because we have alteration in the color vision is sometimes indicative of condition of the optic nerve. Color vision testing is often performed in a neuro-ophthalmologic workups. So the most common color vision test is performed by the Ishara polmatic plates. These plates are bound together in a booklet. In each plate of this booklet are dots of primary colors which are normally integrated to a background of secondary colors. The dots are arranged in a simpler pattern such as numbers or geometric shapes. Patients with diminished color vision may be unable to identify the hidden shapes. Patients with central vision problems like the macular degeneration are more difficult in identifying colors than those with peripheral vision like glaucoma because of central vision identifies color. The Amsler grid is a test used for patients with macular degeneration, such as macular degeneration disease. It consists of a geometric grid of identical squares with central fixation point. The grid should be viewed by the patient wearing the normal reading glasses. Each eye is also not is tested separately. So the patient is instructed to stare at a central fixation spot on the grid and report any distortion in the squares of the grid itself. For patients with macular problems, you find that some of the squares may look faded or the lines may be wavy. So patients with age-related macular degeneration are commonly given these Amsler grids to take home. The patient is encouraged to check them frequently, as often as daily, to detect any early signs of distortions that may indicate the development of neurovascular choroidal membrane, an advanced stage of macular degeneration characterized by growth of abnormal choroidal vessels. Ultrasonography, here the lesions in the globe or the orbit may not be directly visible and are therefore evaluated by ultrasonography. So we have a probe is placed against the eyes, aims the beam of sound. High frequency sound waves emitted from a special transmitter are bounced back from the lesion and collected by a receiver that amplifies and displays the sound waves on a special screen. Ultrasonography can be used to identify orbital tumors, retinal detachment, and changes in tissue composition. Then we have the color fundus photography. Fundus photography is a technique that will be used to detect and document retinal lesions. So the patient's pupils are widely dilated during the procedure. Then visual acuity is diminished for about 30 minutes due to retinal bleaching by the intense flashing light. We have the fluorescein angiography. This one evaluates clinically significant macular edema, documents macular capillary non-perfusion, and identifies retinal and the choroidal neovascularization. That is the growth of abnormal new blood vessels in age-related macular degeneration. Fluorescence angiography is a massive procedure in which fluorescent dye is injected, usually into the antecubital area vein. So within 10 to 15 seconds, this dye can be seen coursing throughout the retinal vessels. Over a 10-minute period, we have serial black and white photographs will be taken of the retinal vasculature. Then the dye may impact a gold tone to the skin of some patients, and urine may turn deep yellow or orange. This is the information that patients have to be educated. This discoloration, however, usually disappears in 24 hours, so the patient do not need to really worry so much. Tonometry is the other procedure, and this diagnostic test measures the intraocular pressure by simply determining the amount of force necessary to indent or flatten a small anterior area of the globe of the eye. The principle involved is that soft eye is dented more easily than a hard eye. So pressure is measured in millimeters of mercury. High readings indicate high pressure, low readings indicate low pressure. Say the normal should be between 10 to 21 millimeters of mercury. The three most common types of tonometers are indentions, ablations, and non-contact. The procedure is non-invasive and is usually painless, so a topical anesthetic eye drop is instilled in the lower conjunctival sac and the tonometer is then used to measure the intraocular pressure. we have the gonioscopy. This visualizes the angle of anterior chamber to identify any abnormalities in appearance and measurements. Geonoscopy uses a refractive lens that can be direct or indirect lenses. The indirect lenses views the mirror image of the opposite anterior chamber angle and can be used only with a slit lamp. The direct gonioscopy lens gives a direct view of the angle and its structures. Perimetry testing. This one evaluates the field of vision. A field of vision is the area or the extent of physical space visible to an eye in a given position. It's the average extent is about 65 degrees upward, 75 degrees downward, 60 degrees inward, and 95% outward when the eye is in the primary gaze, that is looking directly forward. It is a three-dimensional contour representing areas of relative retinal sensitivity. So visual acuity is sharpest at the very top of the field and declines progressively through the periphery. Visual field testing, that is the peripheral, helps to identify which parts of the patient's central and peripheral vision fields have useful vision. It is the most helpful in detecting central scomatous. These scotomas are blind areas in the visual field in macular degeneration and peripheral fields defects like the glaucoma and retinitis pigmentosa. The two methods of peripheral testing are the manual and the automated automated perimetry, right? So on conditions, we have number one, we have the impaired vision, and impaired vision is brought about by the refractory errors. These are vision impaired because we have shortened or elongated eyeballs. This prevents light rays from focusing sharply on the retina. As a result, you're going to have blurred vision from the refractory error, and this can be corrected by eyeglasses or contact lenses. The appropriate eyeglasses or contact lens are determined by the refraction. Refraction ophthalmology consists of placing various types of lenses in front of the patient's eyes to determine which lens best improves a patient's vision. So the depth of the eyeball is important in determining the refractory error. So patients for whom the visual image focuses precisely on the macula and who do not need eyeglasses or contact lenses are said to have normal vision, which is termed as emmetropia. So one of the disorder, the refractory error, is the myopia, which is also commonly referred to as nearsightedness. In myopia, you find distant objects appear blurry, while close objects can be seen clearly. It often occurs when the eyeball is too long or the cornea is there's too much curvature, and this causes light to focusing in front of the retina rather than directly on it. So patients with myopic vision are going to experience blurred distance vision. We can treat them by having concave glasses, which will be used to diverge incoming light, allowing it to focus properly on the retina. We can also use the contact glasses, which are similar to eyeglasses, and they use concave lenses just to correct the focal point of light. We can also perform surgery. Hyperopia, commonly referred to as farsightedness. So hyperopia results in difficult seeing close objects clearly, while distant objects can be seen more easily. It occurs when the eyeball is too short or too little, or there is a too little curvature on the cornea, and this one causes light to focus behind the retina. We can treat this one using the convex lenses. Astigmatism, and in astigmatism we have it causes blurred or distorted vision at any distance and this is due to irregular shape of the cornea or the lens. So instead of having a spherical shape, the cornea or the lens have uneven curves, and this causes light to focus on more than one point, that resulting into astigmatism. All right. It can be corrected by using cylindrical lenses to correct an even curvature of the cornea or the lens, and this will allow light to focus more evenly on the retina. Presbyopia is the fourth refractory error, and it's an age-related condition that makes it difficult for light to focus to close objects. It typically becomes noticeable around age 40, and with aging, you know that the lens of the eye will become less flexible, and this will affect the ability to change shape and focus near objects. Presbyopia can be corrected using eyeglasses with two prescriptions, one for distance and one for close vision. We could also have reading glasses, multifocal contact lenses, and also refractory surgery. Cataract is the next pathology. We could have either partial or complete cloudiness of the opacity of the lens or the lens of the capsule of the eye. This one is the most common cause of blindness worldwide, and commonly affects both eyes, but can also affect only one eye, especially if it is traumatic in nature. We have three types of cataracts. We have congenital cataracts, traumatic, senile cataracts. So we understand why it can be unilateral or bi, right? Okay. And look at incidence. We have around 22 million Americans over age having these cataracts, and 3 million people will undergo surgery annually because of this disease. So in cataracts, you find that the lens, they normally lose their transparency, and this is due to degenerative changes in the crystalline cell structure. So we have clouded lens that normally block the light from shining through them, through the cornea. So images will start appearing blurred, and the brain will interpret this as a hazy image. It has several causes and depends on the type, but the complication, of course, will always lead to complete vision loss. So for for congenital cataracts, it could be as a result of either intrauterine infection, genetic transmission, or a metabolic disorder. While the traumatic cataract, it could be due to either blunt or penetrating ocular injury, electric shock, or radiation or infrared energy exposure. While lastly, the age-related cataracts, which are the senile cataracts, are going to be caused by either chemical changes in the lens proteins in older adult patients, and also the infrared radiation. Kindly notice the opacity of the lens, right? The whiteness here, okay? And that is what is the hallmark sign of the cataracts. Risk factors, we have advancing age. This is the main one, but others we have the smoking, use of alcohol, exposure to sunlight, intrauterine infection for the congenital cataracts that we have mentioned, and so many others. When you're talking about the history, you start with the assessment. You start with the history taking. You ask about the poor vision, the overly, is it cloudy, blurred, dim? What about, is it painless? Is there a gradual vision loss? Is there faded color vision, blinding glare from headlights for the night driving? Or is there poor reading vision, annoying glare from sun or lights, better vision in dim than in bright? And that means this guy has central opacity, right? And we have frequent changes in glasses, frequent changes of glasses or contact lens prescription. That could be found in the history taking. What about the physical findings? In the physical findings, when you carry out your assessment, you could maybe notice a milky white pupil on inspection with a pen light. You could see grain white area behind the pupil in advanced cataract. Or you could have loss of the red reflex in a mature cataract, or change in color of the lens, which may appear slightly yellow or brown. Diagnostic procedures for patients with cataracts, you could do the indirect ophthalmoscopy, and in this case, this could reveal a dark area in the normal homogeneous red reflex. Or you could do a slight limb examination, which will confirm the lens opacity, or a visual acuity test, which the result will establish the degree of vision loss. Remember, for senile cataract, visual acuity test determines the stage of this cataract. It could be hypermature, mature, immature, or incipient. Treatment for cataracts. Before surgery, of course, the surgery is the hallmark. Definitive treatment for this. So before surgery, eyeglasses and eye contact lenses can be used just to improve vision. Sunglasses in bright light and lamps that provide reflected light rather than direct lighting, decreasing glare and aiding vision. In terms of diet, you have to adhere to the recommended diet for the comorbidities. And in terms of activity, the activity restrictions according to the vision. But after surgery, you need to avoid bending at the waist. You also need to avoid performing strenuous activities, and you also need to avoid any other activities that you have been prohibited from, just basing on the healthcare providers' recommendation. Medications for cataracts. For cataracts, you have to prepare for cataract removal surgery. So we could have mediatics, okay, such as the phenylephrine hydrochloride. This can be used preoperatively to dilate the pupil. All right, this one will be found in the autonomic nervous system pharmacology. We could also have short-acting local anesthetics, also the NSAIDs, such as the Lifapac for the pain and inflammation associated with the surgery. You could also have the corticosteroid postoperatively, such as the prednisolone acetate for ophthalmic suspension, or dexamethasone to decrease and control inflammation. The possible side effect of corticosteroid is that they are likely to increase intraocular pressure, so you need to be careful when you are using these corticosteroids. We could also have the broad-spectrum antibiotic, which can be used postoperatively to reduce risk of infection. Then comes now to the surgery, where lens extraction and implantation of intraocular lenses, which is normally facilitated through two major surgeries. You could have pharmacoemulsion, which is the most common, or the extracapsular cataract extraction. So in pharmacoemulsion, the surgeon normally makes a small incision and will insert a probe that contains a small needle that vibrates with ultrasonic energy. While the extracapsular cataract extraction, the surgeon generally removes the lens of the nucleus in the piece through a large incision and aspirates the lens through the eye, leaving the lens capsule behind to support an artificial intraocular lens, right? Okay, so the only disadvantage of the pharmacoemulsion is that the pharmacoemulsion might not be feasible with advanced cataract because the lens nucleus may be very hard. So in pharmacoemulsion, the surgeon normally makes a small incision, which is usually self-sealing and may require no suture. So healing becomes faster in this case. Pharmacoemulsion has the advantage of more rapid visual recovery because of the small incision size and decreased likelihood of suture-induced astigmatism. For the nursing interventions, the nurse should prepare the patient and family for surgery and provide clear explanations about the procedure and postoperative activities and care. The nurse also needs to urge the patient to avoid touching the affected eye after surgery because this is going to help minimize infection. The nurse will also be able to administer prescribed preoperative and post-operative medication and also perform routine post-operative procedures. The nurse will also be able to institute safety measures to prevent falls and assist in early ambulation. Nurse will also be able to apply an eye shield or an eye patch post-operatively as ordered and encourage the patient to avoid activities that is going to increase intraocular pressure, like bending over the waist, making rapid movements, lifting heavy objects, straining with the bowel movement, and forcefully blowing the nose after surgery. The nurse also needs to assess the complaints of a sudden increase in pain accompanied by restlessness, increased pulse rate, which may signal increased intraocular pressure. Also needs to assess for signs and symptoms of surgery complications such as increased eye discharge, sharp pain that's unrelieved by analgesic and deteriorating vision. Okay guys, now we can shift our gears to the third disorder, and this is age-related macular degeneration. So deterioration of the macular portion of the retina, and this is responsible for the detailed vision is such as when used in driving, reading, watching television, performing activities of daily living. So we have types of macular degeneration. We have non-exudative, which is dry atrophic, and exudative, which is wet neurovascular. So we have three stages where we have early, intermediate, and late macular degeneration stage, with the loss of vision increasing as the stages progress. The most common cause of irreversible vision loss is the macular degeneration, and we can be able to see how the viewing will be affected. Okay, central part, blurred vision until you're able to see that. Okay, so we normally have pathological changes which occur primarily in the retinal pigment epithelium, the branch membrane, and the choriocapillaries in the macular region that will result from the hardening and the obstruction of the renal arteries. So in non-exudative type of macular degeneration, we have excess metabolic byproducts forming and accumulating in the retinal pigment epithelium, leading to formation of drusen, which are tiny yellow spots. So we have pigment changes over the macula, and then the vision loss occurs in the retinal pigment epithelium will detach and become atrophic. For the non-exudative macular degeneration, it normally progresses to exudative macular degeneration. So in exudative type, after the atrophic stage, blood vessels underneath the retina will grow. And then forming of these new blood vessels in the macular area obscures the central vision. So in exudative macular degeneration, it normally develops as new blood vessels in the choroid project through the abnormalities in the branch membranes, invading the potential space underneath the retinal pigment epithelium. So these vessels will leak and the fluid in the retinal pigment epithelium will increase, resulting into blurred vision. So those patients, those persons age over 60 are at risk of this macular degeneration, smoking, or if you have family history, obesity, infections like chlamydia, pneumonia infections, or have a short stature, they are at increased risk of having this condition. Also, a diet high in cholesterol and fat and low in antioxidant increases the risk of patient developing this disease. So this macular degeneration normally affects more than 10% of Americans between the ages of 65 and 74, and approximately 25 of those patients you find they will be over age 74. Non-exudative macular degeneration accounts for about 90% of cases, but exudative is responsible for more than 80% of cases involving severe vision loss or legal blindness. So macular degeneration is more common in white people than in black and more severe in people with light eyes. In terms of gender, females are at a greater risk than males, and of the patients with non-exudative macular degeneration, 10 to 20% normally progress to exudative, okay, from non-exudative to exudative. So the incidence of macular degeneration increases with age, with a significant rise after the age 70, and is the leading cause of irreversible severe vision loss in people over age 50. It can complicate into blindness, nystagmus, conversion, of course, of non-exudative to exudative, the patient being depressed, and frequent falls, right, which is a safety problem. So when you are doing assessment, of course, you are supposed to get the non-exudative, which is a dry macular degeneration type, and the exudative. So in history taking for the non-exudative, the dry, patients are going to present difficult with night vision and changing light conditions. They're going to report gradual loss of vision in one or both eyes, most commonly reported as difficult reading or driving, or the need for a bright light or a magnifying lens for activities that require fine visual acuity. Patients could also report change in visual field, difficult distinguishing textures and subtle environmental changes, and impaired depth perception and fluctuation in visual acuity. Vision better on some days and worse on other days. For the exudative, the wet type of macular degeneration, patients are going to report distortion or loss of central vision, usually in one eye. Then you could have blind spot, that is scotoma, in the center of the page when reading, right? You see a blind spot. Then you could have intermittent blurring of central vision that can be acute or has gradually worsened. Also, distortion of straight lines and generalized haziness of overall vision, abrupt onset and rapid worsening of visual disturbances, and fragmented appearance of letters and having the accident. When you do the physical findings, what do you find out? For the non-exudative type, which is a dry type, you're going to see tiny yellowish spots beneath the retina, and you can also observe the atrophy of the retinal pigment epithelium. What of the exudative type, which is the wet type? We're going to have the subretinal fluid accumulation or hemorrhage with a grayish green discoloration that's sometimes surrounded by a pigment ring. We'll also see an exudate and the fibrovascular scarring, especially in the advanced stage. So, how can you diagnose this macular degeneration? We could start with the imaging, where we do the fluorine angiography, which may show the leaking vessels, the choroidal neurovascular membranes in the subretinal neurovascular net. Or we could also do the indocyanine green video angiography, which will be able to identify hidden or occult choroidal neurovascular membranes. We could also have the optical coherence tomography, which may help identify choroidal neurovascular membranes, subretinal fluid, and retinal thickening or follow disease progression. Could also have the fundal autofluorescence, which will reveal lipofuscin accumulation. All right. What about the direct procedures? We could do indirect ophthalmoscopy, which may show changes in macular degeneration region of the fundus, or the amscular creed test, which may show visual distortion. The visual acuity test will determine the degree of vision loss, while the fundoscopic or the ophthalmic examination may be performed where the tonometry will measure the eye pressure, the intraocular pressure, The electroretinopathy will evaluate retinal rods and cones and may be done just to follow disease progression. What about the treatment, guys? We have no proven effective treatment to halt progression of macular degeneration, okay? All right, and the treatment just focuses on slowing progression. So you wrap around sunglasses to provide protection from direct sunlight, fall prevention with progressive vision loss, and smoking cessation. For the diet, you can do diet high in vitamins A, C, E, and the beta carotene and zinc. We also have the increased intake of dark green and leafy vegetables rich in carotenoids. We could also do increased intake of fish high in omega-3 fatty acids. This will be so important for this patient. In terms of medication, we could do zinc and copper supplements and vitamin A, E, and C and beta carotene supplement just to improve the vision. Vascular endothelial growth factor inhibitors such as the ranibizumab and bevacizumab and the aflibercept for exudative macular degeneration will be injected intravitreal per prescribed interval, which will range maybe every 4 weeks to every 8 weeks as part of the treatment. So we could do thermal laser photocoagulation for exudative macular degeneration, which may slow the progression of severe vision loss. We could also do photodynamic therapy with phytoporfin. In terms of surgery, we could do the vitrectomy just to remove subretinal blood or the macular translocation to shift the macula away from the choroidal neurovascular membranes. So as a nurse, you have to determine the extent of vision loss and provide assistance where necessary, including even amputation and other safety precautions. To assist the patient with adaptation to the accommodative changes in vision, including providing assistive walking aids. Also encourage the intake of foods high in vitamins A, C, and E, beta carotene, zinc, and omega-3 just to improve vision. Urge the use of eye protection with ultraviolet light exposure and encourage smoke cessation as indicated. You institute safety precaution measures to prevent falls and other injuries related to vision changes and offer the patient emotional support, assist with positive coping strategies, encourage the expression of fears, concerns, especially those related to vision loss and its impact in patient's ability. Assist the patient with the use of visual fields such as the magnifiers, the tablet computers, which can be helpful because of the ability for the text enlargement and backlighting, right? You could also assist in giving the eye drops, of course, and eye ointments, which are the mainstay treatment of ocular conditions, right? And you have to prioritize administration of this medicine because they can prolong the condition, may present a patient risk to patient visions. Okay, they can cause discomfort if not controlled, if not used, can lead to loss of vision or even blindness. And they are used to treat acute and chronic conditions. Eye drop must be instilled before applying the ointments, and this is equally important because the ointment will affect the absorption of the eye drop, right? So you start with the drop before applying an ointment, right? Okay, so on the case for the trachoma of course is also is an infection caused by chlamydia bacteria, and it causes inflammation and thickening the upper eyelid. So we have the 5 stages of trachoma, starting with the inflammation follicular. In this initial stage, you find the inner surface of the eyelid shows 5 or more follicles, which are small bumps. Each at least is about 0.5 millimeter in diameter. So this stage is characterized by inflammation and is typically seen in children. Stage 2 is the inflammation intense, right? And the inflammatory thickening of the tarsal conjunctiva obscures half normal deep tarsal vessels. So the inner surface of the eye becomes intensely inflamed and thickened. This stage will involve severe irritation and more aggressive, indicating more significant infection. The third stage, according to WHO classification, is the scarring. And as this disease progresses, repeated infection cause scarring on the inner surface of the eyelid. These scars can appear as white lines or bands. Okay. And the presence of this scarring indicates that the disease has caused permanent damage now to the conjunctiva. It's now affected. Then followed by trichiasis, which is simply the scarring causing the eyelashes to turn inward and rub now against the cornea. Okay, and the rubbing of the cornea is what we refer as trichiasis. So this inward turning of the lashes can lead to corneal abrasion and discomfort. Notice the normal one and now the abnormal one. They'll be now be rubbing on the cornea, okay, the dome-shaped surface. Lastly, we have the corneal opacity. This is the final stage of the trachoma and is marked by corneal opacity where the cornea becomes clouded. Notice, okay, clouded. And this cloudedness can lead to partial or complete blindness if untreated. So corneal opacity is usually as a result of persistent trauma from trichiasis and secondary infection. What about glaucoma? Glaucoma is a group of eye conditions that damages the optic nerve, often leading to increased intraocular pressure. And this normally affects majorly the peripheral vision. So we have subtypes of glaucoma. We have the primary open angle glaucoma. This is chronic in nature compared to angle closure glaucoma, which is acute in nature. So the primary open angle is chronic, where the drainage angle formed by the cornea and the iris remains open, but the trabecular meshwork is partially blocked. So this leads to gradual increase in intraocular pressure, leading to optic nerve damage. It could be symptomless in the early stages. The later vision loss progresses slowly and often unnoticed until advanced stages. For the ankle closure is acute condition. It's an emergency. So the draining ankle is suddenly blocked, causing rapid rise in intraocular pressure. And symptoms will include severe eye pain, nausea, redness, blurred vision. It's an emergency condition. It requires immediate medical attention to prevent permanent vision loss. The third one, we have normal tension glaucoma, which is characterized by optic nerve damage occurring through the intraocular pressure, though the intraocular pressure will be in normal ranges. Cause is unknown, but is believed to be due to particular sensitive optic nerve and reduced blood flow to the optic nerve. The fourth is secondary glaucoma, which is caused by underlying conditions such as inflammation, trauma, steroid use, other diseases. Remember we said corticosteroid, they increase the risk of increased intraocular pressure. Secondary glaucoma can be open angle or angle, can result into either. Lastly, you have congenital glaucoma, which is present at birth due to developmental issues in the eye drainage systems. Symptoms in infants include enlarged eyes, cloudedness, and excessive tearing. For the retinal detachment, it's a serious eye condition where the retina's light-sensitive layer at the back of the eye separates from the underlying tissue. These conditions can lead to vision loss if not promptly treated. We have four major subtypes of retinal detachment, starting with the rhegmatogenous retinal detachment. that's characterized by flashes of light, where we have sudden, brief flashes of light in the peripheral vision. Patients seeing floaters, which are tiny specks or strings drifting through the field. Patient could present with shadow or curtain effect, that is descending from the top across the eye, or blurred vision, where there is gradual worsening of vision. So you treat using the pharmacoagulation therapy. A laser is used to seal those retinal tears. The second one is traction retinopathy, retinal detachment. And patient is going to present with distorted vision, where images will appear distorted or wavy. We're going to have reduced vision, which is often severe. And for the floaters and flashes, they may be less common, but they still can appear. Then you have the dark areas in the vision, in the vision. So you can treat using the vitrectomy, which is the primary treatment, where the vitreous jelly will be removed and scar tissue is cut away from the retina to relieve the traction. The third type is the exudative or the serous retinal detachment. Here, the patient is going to present with visual disturbances, blurred vision, or sudden loss of vision. There is no pain here, redness. The vision field loss could be partial or complete. So you have to treat the underlying cause, and we could use the laser photoaugmentation or the cryopexy just to seal off any leaking blood vessel. The last one is a combined mechanism retinal detachment, which is consisting of the first two, with the traction and the rigmatogenous types. So the patient is going to present with visual impairment, that is progressive vision loss or flashes and floaters, and distorted vision, where images will be appearing wavy and distorted. So you treat using the vitrectomy, the laser surgery, or the scleral bulking. Remember, in all types of the retinal detachment, they require early intervention to preserve vision. We have postoperative care, just to maintain specific head position to keep any gas bubbles in place. And lastly, follow-up care appointments are essential to monitor the healing process and ensure that the retina remains in good shape. We also have the other parts of types of eyeball removal. You know, the eye removal that is medically, we normally refer to it as enucleation or evisceration. And it's simply a procedure that is performed for various medical reasons, including trauma, advanced disease, or severe infection. So we have three major types of eye removal. The first one is enucleation, which involves the removal of the entire eyeball, leaving the eye muscles or the remaining orbital content intact. It is typically performed for intraocular tumors like the retinoblastomas or the melanomas. It could also be performed due to severe trauma or painful blind eye, endophthalmitis, or uncontrolled eye infection. Right? The second one is now evisceration, and evisceration involves the removal of the eye contents of the eye, leaving the sclera, which is what we have commonly referred to as the white part of the eye, and the attached extraocular muscles will be left intact. And it's usually indicated in cases of endophthalmitis, that is the inflammation within the eye, severe trauma, or painful blind eye, while preserving the sclera, which can provide a better cosmetics result when fitting an ocular prosthesis. We also have the exteration. Exteration is a more extensive procedure that involves removal of the eye contents of the orbit, including the eyeball, extraocular muscles, fat, sometimes part of the surrounding bone and eyelids. It's indicated for extensive malignant orbit tumors or the severe life-threatening condition that spread beyond the eye. So finally, we can end with some of the age-related changes that normally affects the eye. So as you age, you're likely to experience some conditions like the presbyopia, which is a refractory error, a condition that typically begins in the early mid 40s. It's characterized by loss of the eye's ability to focus on near objects, and people with presbyopia often find it difficult to read small print, may experience eye strain and headaches, especially during tasks requiring close focus. Number two is cataracts, and cataracts we have said is the leading condition of blindness. It usually develops after the age of 60 and involves clouding of the eye's natural lens. This condition leads to blurred vision, increased sensitivity to light, the appearance of halos around lights. Cataracts can significantly impair daily activities, including driving at night and reading. The other condition is age-related macular degeneration, which affects the macula, the central part of the retina responsible for sharp or clear vision. And it's more common in individuals over 60. It causes blurred central vision and can make it difficult to recognize faces and perform tasks that require detailed vision, like reading and driving. Fourth is glaucoma, and is a group of conditions that will damage the optic nerve, causing, of course, due to increased intraocular pressure. It typically affects people over 40 with a risk or increasing age being a risk factor. Glaucoma can also lead to patchy blind spots in the peripheral and central vision and in advanced stages in tunnel vision. Dry eyes, which is more associated with the Synogron's disease and is common in individuals with over 50. Dry eye occurs when the eyes do not produce enough tears and tears evaporate too quickly. Symptoms include dryness, itching, burning, redness, leading to discomfort and poor vision. Diabetic retinopathy is a complication of diabetes that damages the blood vessels in the retina. It can also occur at any age, but it is more likely later in life with prolonged diabetes. And symptoms of diabetic retinopathy include the floaters, blurred vision, vision loss, which can progress without timely management. The Fuchs endothelial dystrophy affects individuals over 50 and involves degeneration of corneal endothelial cells. It results in blurred vision, glare, and halos around lights. This disease can worsen over time and leads to significant visual impairment. Retinal detachment, which we have looked at, becomes more common after age 50 and involves separation of the retina from its underlying tissue. Patient is going to present with sudden appearance of floaters, flashes of light, and shadow over the vision field. It requires prompt medical attention to prevent permanent vision loss. For vitreous detachment, it occurs in patients who are over 50 years and it involves separation of the vitreous jelly from the retina. So this can cause floaters, flash of light, and other visual disturbances. While usually less severe than retinal detachment, it can still lead to complication. Reduced pupil size. As people age, the diameter of the pupil decreases, reducing the amount of light entering the eye. This change, common after age 60, can make it harder to see in dim light, and it will necessitate the need for more light for activities like reading. For decreased contrast sensitivity, you will have a reduction in contrast sensitivity common after age 50, 60, and it makes it difficult to distinguish between different shades of light and dark. This can impact night driving and reading in low contrast situation, posing safety and daily living challenges. Keratoconus is the last condition and it starts in adolescence or adulthood. It can progress with age, all right, and it involves thinning and bulging of the cornea, leading to blurred vision, increased sensitivity to light, and frequent changes in eyeglasses prescription. Okay, guys, that marks the end of our presentation on eye conditions, right? Remember to go through the major types of ocular problems like glaucoma, cataracts, macular degeneration, and so on and so forth. Thank you so much. See you again.